Good morning, everybody. And for those of you who have come from Canada or the United States, good evening. I'm still recovering from the jet lag, but it's been terrific. This is my first trip to India, and it really has been fascinating being in Mumbai and being able to visit this hospital and participate in the meeting, and of course to give the plenary lecture. The plenary lecture, well, in fact, you just heard it from Francesco Bertolini. He pretty much gave everything I wanted to talk about, but there's going to be a major difference between what Francesco said and what I said, which is, he said it in Italian, I'm going to say it in Canadian. Oh, if you're going to take a photograph, can you take my better side? Okay, that's okay. Right, so there's been so much emphasis over the last day, yesterday and so far today, about the anti-angiogenic basis of metronomic chemotherapy. And much of that emphasis came from studies from my own lab. So by way of example, here's a paper that I wrote with the late, great pediatric oncologist and researcher Barton Kamen, the anti-angiogenic basis of metronomic chemotherapy. And you can see it was written and published in Nature Reviews Cancer in 2004. So what preceded that? I want to just give a little bit of a history behind this, how it happened from my perspective and how things are changing. So I had an idea around 1990, and the idea is that chemotherapy, I wasn't thinking about metronomic chemotherapy, conventional chemotherapy ought to have anti-angiogenic effects. And it's a very simple idea which has been alluded to already in this meeting. Number one, chemotherapy drugs kill or preferentially target cycling cells. Doesn't matter what they are. It could be bone marrow progenitors, hair follicle cells. They could be dividing endothelial cells that are present in a growing tumor neovasculature. Now, as was mentioned yesterday by Dan Duda, the frequency of these dividing endothelial cells and angiogenic blood vessels is very low. The figures that you see in the literature are just a couple of %, but nevertheless, they may be important for overall sprouting neoangiogenesis. If that's true, what I reasoned was that therefore chemotherapy should have vascular targeting or anti-angiogenic effects and cause a tumor response even when the tumor cells themselves are resistant to that particular chemotherapy. And this was a hypothesis that was published in this paper called in a journal called Bioessays, a journal that's published in the UK. Now, the contents of this paper and this particular hypothesis I discussed over the phone in 1998, or rather in 1990, just before I wrote this paper, with Judah Folkman, who I had just met. So I went through this idea and I said, you know, you're working on anti-angiogenic drugs, trying to discover anti-angiogenic drugs, and maybe we've been using them in the clinic without knowing it for years, chemotherapy. And so I went through this hypothesis, and I said, you know, there's something that's not right about this, or something that's inconsistent. For example, a highly angiogenic tumor is renal cell carcinoma. We all know that. But there's no real effective chemotherapy for renal cell carcinoma, despite the fact that it's highly angiogenic. So I discussed this with Dr. Folkman and said, well, you know, maybe this hypothesis just doesn't have merit, and chemotherapy doesn't really have any kind of vascular targeting or anti-angiogenic effect. Okay, fast forward. 8 years later, I had another conversation with Dr. Folkman, and Folkman said at that time, actually, chemotherapy does have, or can have, a very potent anti-angiogenic effect. It's how you dose and how you schedule a drug. Now, I want to raise this point because several people have said I'm either the father of this field or the grandfather. No, that's not correct. So let me set the record straight. What happened was that Folkman said that someone in his lab named Tim Browder, who tragically died at a young age, came up with this idea. And the idea is that when you give chemotherapy in a pulsatile fashion at the maximum tolerated dose, you see in mice an anti-angiogenic effect. that is to say endothelial cell apoptosis, in the tumor blood vessels of subcutaneously transplanted primary tumors. Very important point that I'm going to come back to in a moment. But what happens is that putative potential anti-angiogenic effect is lost during that rest period before you can begin the next cycle of MTD chemotherapy. There's some sort of repair process, he said, that was taking place. They didn't know what it was. But Tim Browder, in his lab, a hematologic oncologist, came up with the idea of, well, what we have to do, he said, to maximize this anti-angiogenic effect is to give the drug more often, shorten the breaks. And actually, if you look at the paper, what they did is a weekly schedule. Cyclophosphamide was given every other day for 6 days, a short cycle, and then there would be a 2-week break. And then they would begin the next cycle of therapy. And the idea would be that this would maximize the anti-angiogenic effects of cyclophosphamide in the system. And that's what they showed in the paper. An amazing paper, really, in retrospect. Now, when I heard about these results, again, 2 years before they were published, the idea that I had was a hypothesis following on these pioneering results. And the hypothesis is that maybe combining a VEGF pathway targeting anti-angiogenic drug with what came to be known as described by Francesco, metronomic chemotherapy, will improve therapeutic outcomes. Remember also that Dr. Folkman called this way of giving chemotherapy anti-angiogenic chemotherapy. After our paper came out, which I'll show you in a moment, and the term metronomic was described, I don't think he was very happy about that. He really preferred the terminology anti-angiogenic, whereas I personally preferred the term metronomic, and I'll explain why in a moment. But the hypothesis for our paper, which ironically came out at the same time, I won't go into the reasons why, is that VEGF is a survival factor for angiogenic activated endothelial cells expressing VEGF receptor 2. And thus the extent of damage to endothelial cells and angiogenic blood vessels caused by a given chemotherapy regimen should be amplified by targeting VEGF function, by targeting the survival function of VEGF. And so that led to this experiment, a series of experiments undertaken mainly by a pediatric oncologist in my lab, Yanula Clement, working with another pediatric oncologist, Sylvain Baruchel at Sick Children's Hospital in Toronto. And what Sylvain and Yanula came up with was this experimental design. Okay, this is a large human neuroblastoma growing in the skin of mice. This is a subcutaneous tumor transplant, all right? And when the tumor got very large, a protocol was established in which the drug was given at, through an infusional pump at fairly high drug concentrations over a 3-week period. So really what we did was an induction protocol using vinblastine. And then Yanula worked out a maintenance schedule where the drug was given intraperitoneally every few days, every 3 days, at about 1/10 the maximum tolerated dose. And that was just maintained indefinitely because the toxicity was minimal. And then in another group, we added DC-101. DC-101 is an antibody to mouse VEGF receptor 2. So now here are the results. You can see vinblastine alone worked. DC-101 caused a growth delay as well. But it was really the two together in this induction maintenance type regimen that gave this prolonged survival effect. In effect, the mice were essentially cured and the tumors completely disappeared. So these papers, as I said, came out at the same time, and indeed in the paper we did show evidence that combining vinblastine with DC-101 gave a greater degree of endothelial cell apoptosis in the tumor blood vessels of this primary transplanted large neuroblastoma. And we didn't see evidence of endothelial cell apoptosis in other tissues or organs in the body. So so the idea then grew that became kind of established that targeting endothelial cells would be a basis for the anti-angiogenic mechanism of low-dose metronomic chemotherapy. Now, as you've already heard, is another mechanism targeting bone marrow-derived circulating cells like endothelial progenitor cells. And one thing that haven't been mentioned in this meeting, very interesting, is that there are certain drugs like topotecan and adriamycin and irinotecan, when you give them at low extended schedules at low doses, have this interesting effect of suppressing the function or expression of HIF-1 alpha, which is a major driver, of course, of VEGF and other pro-angiogenic growth factors, and therefore angiogenesis. Now, I'm going to come back to these other points about direct tumor cell targeting and stimulation of the immune system in a few moments. But again, I'll go through this quickly because Yuval and Francesco Brunelli have already, discussed this idea that when you give maximum tolerated dose chemotherapy, you can get a tumor response. If the tumor is sensitive to the drug, you can get tumor cell kill, something that you want. But then, as Yuval mentioned yesterday, you can get this host response, and the host response could be egress of bone marrow-derived cells, including endothelial progenitor cells in the bone marrow compartment, tumor homing, residence in the tumor that can facilitate tumor growth, but you can block this response giving an anti-VEGF therapy, say a monoclonal antibody to VEGF or VEGF receptor 2. This is one way that you can inhibit the host response. And that work, as you know, again, I'm going to go over this. You've heard about it several times. The work that was published in Cancer Research in 2003 with Francesco, and then a couple of papers, one in Science and one in Cancer Cell, again with Francesco and Yuval, describing this host phenomenon. And here's another example of that. This is a paper from Cancer Cell where if you give paclitaxel to mice that have green fluorescent bone marrow-derived cells, you get this influx into the primary transplanted subcutaneous tumor, Lewis lung in this particular case, of these bone marrow-derived cells, and that phenomenon can be completely blocked or largely blocked by giving an antibody that targets the VEGF pathway, VEGF receptor 2, and so on. But this, as you've all described, getting this host response can actually be prevented by giving chemotherapy in a continuous low-dose metronomic fashion. And in that case, you don't even have to use something like DC-101 to block the host response. Okay, so now what are the advantages? As we've discussed it throughout the meeting, reduced acute toxicity, increased convenience for patients, and reduced cost when using oral off-patent drugs. Could be practical as a long-term adjuvant or maintenance therapy, and can be integrated long-term with targeted therapies. Significant advantages. However, there are a lot of disadvantages with this concept, and that's one reason why it has remained largely a niche concept. And I want to go through these and tell you how we're tackling a few of them. Number one, you often hear oncologists saying, well, look, if you administer drugs at lower doses, won't that facilitate the development resistance? That's from very old work decades ago, where if you take tumor cells, expose them in culture to low concentrations of drug resistance will develop more quickly. That does not apply in vivo when you're using metronomic chemotherapy regimens where the mechanism of action is different, where you have all these multi-targeting effects. So I think that's a myth, but it's still something that's widely believed. If toxicity is less with metronomic chemotherapy, then won't some oncologists say the anti-tumor efficacy also be less? Because, there's this mantra that toxicity is a surrogate for efficacy. No toxicity means maybe no efficacy. Again, I think another myth that has to be challenged, but there it is. Oral chemotherapy has some disadvantages compared to IV chemotherapy. Pharmacokinetic heterogeneity, patient compliance, are they actually taking their pills? Chronic metronomic chemotherapy. Some people say, well, look, it may be carcinogenic. Well, that's theoretically possible, but if a patient has metastatic disease and is going to die within a year, I don't think that that's a particularly compelling argument not to use it. Could be important, though, for adjuvant therapy. No validated predictive markers as yet. This is a big problem for the angiogenesis field, and it's also a problem for the metronomic chemotherapy field. And I'll come back to that at the very end. What I'm going to concentrate on are these last 2 points. The mechanisms remain rather vague, at least at the molecular level. So in an era of precision medicine, wanting to know the molecular targets and mechanism of action, this is a drawback in some people's minds to metronomic chemotherapy, regardless of the therapeutic results that you get. And then finally, there's this view that, okay, there's a lot of interesting results that have been published in mice, but they're mice. Are those preclinical results relevant to the clinic? And a lot of oncologists and researchers say, maybe not. So, after our paper and Dr. Folkman's paper came out, because I'm going to concentrate now on that last point, there were a number of editorials about the Folkman-Browder paper in Cancer Research and our paper in the Journal of Clinical Investigation. Now, this particular editorial is from two very close friends of mine, Josh Fiedler and Lee Ellis at the MD Anderson. And yet, they castigated us in this editorial. Well, they were both, complimentary, but say, look, guys, hold on here. The Folkman and Kerbel studies both utilize ectopic, subcutaneous, transplanted primary tumors. And any of you have heard Dr. Folkman over the years who would say, he would get up and say, if breast cancer occurred in the skin, dermatologists would cure cancer. And he was very much opposed to the use of the sort of models that both Folkman and I used in our studies. They recommended that we should use more clinically relevant models, for example, orthotopic primary tumors, or, even better, treatment of metastatic disease to validate their results. And that editorial, along with a couple of other things that happened a few years later, convinced us maybe this is the way to go. We want to validate our results using these more stringent, challenging models. And actually, it's because of the results of these models that I really became convinced about the prospects, the potential of metronomic chemotherapy. So what we started to do, it took us about 5 years to finally get around to what Lee Ellis and Josh Fiedler recommended, is that we have developed a whole series of human tumor xenografts where we treat metastatic disease. We're now doing this with mouse tumors grown in syngeneic immunocompetent mice, so we can do immunotherapy experiments. So we started this about 12, 14 years ago, beginning with breast, then melanoma, ovarian, kidney cancer, liver cancer, and colorectal carcinoma. And in the case of breast melanoma and colorectal and renal, this is the sort of thing that we're actually treating. We're not treating in mice an established primary tumor. We're doing something that's very unusual in preclinical oncology, which when you think about it is kind of bizarre. Because most phase 3 clinical trials deal with patients that have metastatic disease, usually incurable metastatic disease. That circumstance is rarely recapitulated by preclinical basic researchers. So in the case of breast cancer, what we're treating is disease in the lungs, lymph nodes, sometimes in the liver. We're not necessarily treating established primary tumors. I won't go through how we develop these tumors. Each one of these models takes about a year or so by serial selection in vivo of metastatic disease after orthotopic transplantation and primary tumor resection. Okay, so we've got these metastatic models. Really, are they better? That's one of the things that we've been trying to address. I mean, are they really more clinically relevant? Do they give results that are more clinically meaningful? Well, we have a limited database to suggest that maybe they are. So let me take you through this little story. Here's a paper that was published in 2003, preclinical evaluation of the TKI known now as sunitinib, or Sutent, as a single agent or in combination with standard of care therapeutic agents for the treatment of breast cancer. Now, many of you may be aware that this drug, sunitinib, is approved clinically, mainly for kidney cancer and a few other rare cancers. It's not approved for breast cancer or any other major malignancy. But when it was first developed by the company that discovered the drug, Sugen, which was then taken over by Pharmacia, which was then taken over by Pfizer and became a Pfizer drug. They were developing it for one of the big four, the usual: breast, lung, colon, prostate. And the first paper that was published was on breast cancer. And you can see the conclusion was that their results with the drug is effective in preclinical breast cancer models and suggests that it may be useful in treatment of breast cancer in the clinic. Well, what did they do? They actually looked at about 4 different models. Most of them were dealing with primary tumors in mice. One was a transgenic model. You give the drug down here, and you get an effect. And these are primary tumors. The drug works, stop giving it, the tumors start to regrow. Give a second cycle of therapy, you get another response. Second model, chemically induced mammary carcinomas in rats. So by definition, these are orthotopic tumors, and depending on the dose of drug that you gave and the schedule down here, you could either get stasis and then slow regression after you stop giving the drug, or even regression. The drug works. Third model was a human tumor xenograft, subcutaneous transplant of human breast cancer cells. Here's the control. Here's sunitinib. And now they add docetaxel, either giving it alone or in combination. And you can see this additive or synergistic-like effect when you use the combination, which they repeated using 5-fluorouracil or adriamycin, 2 clinically approved drugs for breast cancer. And here's the schedule down here: docetaxel plus sunitinib, and then sunitinib maintenance. Okay? It works. Now, that preclinical paper was actually seminal in Pfizer undertaking not 1, but 4 randomized, double-blind placebo controls of this drug in women with metastatic disease. And you can see the name of the trials here. The 2 of them are first line, 2 of them are second line. 3 of them involved addition of chemotherapy with the sunitinib, either docetaxel or capecitabine, or paclitaxel, in one case head-to-head. And now, all 4 of these trials failed. And, you know, when I give this lecture, I sort of a black joke. I say, how much do you think this slide cost? It would be about $400 to $500 million, given the cost of a randomized phase 3 trial now in the United States, Canada, or Western Europe. And that's one reason why these new drugs are so expensive when they make it to market. Drug companies are trying to, you know, recoup the loss of all of these failed phase 3 clinical trials, which are so common in oncology, despite the fact that there were prior positive preclinical data and often prior positive phase 2 data that looked positive. So we went back and we did what Sujan did, you know, all those years ago. We had a primary breast cancer, MDA231, a variant of it called LM24. It's a triple-negative breast cancer. Put it in the mammary fat pad. So these are orthotopic, not subcutaneous tumors. And give the drug, sunitinib. And you can see that we get a response very similar to what was published all those years ago. But in a second series of experiments done by a sabbatical worker from Spain, Raquel Munoz, and a technician in my lab, Shan Man, who's been with me forever, what was done was we did a mastectomy. We removed the primary tumor, allowed the mice to get metastatic disease, and then began the treatment using the same dose and schedule of the drug, and used median overall survival as an endpoint. And in all of these experiments, we saw no activity. And if we added chemotherapy to the sunitinib, in this case paclitaxel, the result was no better. All right? So sunitinib alone plus paclitaxel was ineffective. Now, this is not a sunitinib problem. In these models, we have tried bevacizumab, we've tried pazopanib, and we've tried DC-101, the antibody to VEGF receptor 2. They all failed. In the metastatic setting, they all were efficacious in the primary tumor setting. So a major difference between primary tumor, the conventional approach, even orthotopic, versus treating metastatic disease, established metastatic disease. Now, interestingly, when we did the same type of experiment using chemotherapy, and here we were kind of throwing darts, I have to admit. We just took 2 off-patent drugs, cyclophosphamide, and UFT, a 5-FU prodrug, similar but not identical to capecitabine. And honestly, we chose those 2 drugs because they're common, they're available, and they're oral. And we tried a doublet regimen. And interestingly, in the pilot experiment, in the metastatic setting, it was highly effective. We repeated the experiment, and again, highly effective, the 2 drugs, at least when used as a doublet, not either agent alone. And the really interesting thing is that when we evaluated the same doublet regimen on the same tumor grown as a primary tumor, orthotopically in the mammary fat pad, very modest growth delay, no effect at all of the UFT, and you get this rather unimpressive effect of cyclophosphamide. So I wanted to show this because, you know, this result, along with the one that I just showed you with sunitinib, has raised this question on my mind. How can you say, at least in this model, that metronomic chemotherapy, its major mechanism is anti-angiogenic? I don't see how that's possible, because when we use anti-angiogenic drugs in the metastatic setting in this model, they're simply ineffective. Now, why is that? The reason is we think that what we've been doing over the last couple of years is asking or addressing this question. Primary tumor, responsive to an anti-angiogenic drug. Metastatic disease, mainly in lymph nodes, lungs, not responsive. Why? And so we began a collaboration with Hal Dvorak in Boston. The results finally have been submitted for publication with another group in England led by Andrew Reynolds. Now, the answer seems to be vessel cooption. And this is what actually was first reported by a pathologist named Francesco Pizzella in 1996. I think all of us, at least myself included in the angiogenesis field, kind of ignored this. And what Pizzella said was the following. Look at the normal lung, all right? It's air sacs, and the air sacs are surrounded by huge numbers of blood vessels, and these membranes or septa surrounding these alveolar air sacs. Now, if you look at an angiogenic non-small cell lung cancer growing in the lung, you can see evidence of angiogenesis and disruption of the normal tissue vasculature. But what Pizzella noted is that there are many, many instances, based on his analysis, of what he called non-angiogenic non-small cell lung cancers. The normal architecture of the lung is preserved. And what happens is the sacs, the air sacs, simply become filled up with tumor cells, and they hijack the normal, abundant, existing vasculature. They don't need to form new blood vessels. They don't need sprouting neoangiogenesis. And what are the lungs programmed to do? They're programmed to provide oxygenated blood to the rest of the body. So we didn't know this at the time. This is retrospective. When we sent primary tumor samples and lung metastases to Dr. Dvorak, a few months later, he wrote back and said, well, gee, there is a major difference in the vasculature. The primary tumors are angiogenic by morphology, and the lung metastases are not. They're either cuffing around the septa, the membranes of these alveolar sacs, or they're growing within these alveolar sacs. So primary tumors are angiogenic. This is from Hal Dvorak. I won't go through the details. And then when Hal began to look at other tumor models in-house, B16 melanoma, primary tumor angiogenic. You look at lung metastases after IV or inoculation or spontaneously arising, no angiogenesis. And even spontaneous polyomaty, genetically engineered mouse models of breast cancer, the primary tumors are angiogenic, according to Hal, but the metastases in the lungs are largely non-angiogenic. Even when the lesions start to grow fairly large, they're growing within the alveolar sacs. Well, if there's no angiogenesis, it's no wonder that an anti-angiogenic drug is going to have minimal efficacy, or maybe even no efficacy, when treating lesions that look like this, growing in sites like the lungs, or the liver, or the brain, or the lymph nodes. Is that a mouse phenomenon? Well, this has just been submitted for publication by Andy Reynolds. I'm a co-author of this study. But what has been done here is that hundreds of breast cancer lung metastases or liver metastases from patients have been analyzed for angiogenesis. And the vast majority of them are not angiogenic. They're showing evidence, again, in these red bars here, of being largely driven by vessel co-option. So that's a stealing or hijacking of the vasculature, in the lungs, clinically. So this is not just a preclinical phenomenon. It's very common in human breast cancer and lung mets. It's also pretty common in liver metastases of colorectal carcinoma patients. In addition to perhaps explaining examples of intrinsic resistance to anti-angiogenic drugs, we just had a paper come out in JNCI a few weeks ago showing that co-option of liver vessels not sprouting angiogenesis may drive acquired resistance to sorafenib in hepatocellular carcinoma. And there's an accompanying editorial by Francesco Pizzello on this particular paper. So with all this in mind, here's what major take-home message. I think a next challenge, the next frontier for, I wouldn't say anti-angiogenic therapy, for vascular targeting therapies, this is the question that's foremost in my mind. Can these co-opted, stolen tumor blood vessels be targeted by what I would call an anti-vascular, not an anti-angiogenic, but an anti-vascular therapy? Maybe combination anti-angiogenics, because Ang2, for example, has been implicated as being involved in vessel co-option. What about vascular disrupting agents? What about anti-invasive agents? I won't go through the rationale of that. What about immunotherapy? I'm intrigued by the idea that maybe immune checkpoint controls may have a role to play in targeting vessel co-option, based on the assumption that these blood vessels are not completely normal. And finally, and most importantly, is this one of the ways that chemotherapy, when it's combined with an anti-angiogenic drug, works? Not just by inhibiting angiogenesis, but by targeting these co-opted vessels. And I'm particularly interested in this from the point of view of metronomic chemotherapy, that it does have blood vessel targeting effects, but they're not classically anti-angiogenic. Anyway, I put that up for food for thought. So again, coming to the end, there's been mention made about direct tumor cell targeting effects and stimulation of the host immune system. And I mean, I've become interested in this because, again, I'm trying to come to grips with how, in our models, where we get sometimes terrific therapeutic results treating advanced metastatic disease, where there doesn't seem to be much or any angiogenesis present, how do you explain the therapeutic effects of these metronomic regimens? So this gets to, what Francesco was saying, during his talk. Number one, metronomic cyclophosphamide. When we think about immunity and metronomic chemotherapy, the word cyclophosphamide, as was mentioned by Francesco, keeps coming up. And there are about 20 papers in the world's literature showing that low-dose cyclophosphamide, maybe actually more than 20, having this immune-stimulating effect. Mainly, it's thought classically by, as Francesco mentioned, targeting these T regulatory cells. But there may be other mechanisms involved as well. Now, I want to bring this up for another reason. I mean, look, we have to be entrepreneurial in this field. And the fact of the matter is that immune checkpoint therapy, immunotherapy, oncolytic viruses, you name it, are taking over the world of experimental and clinical therapeutics in cancer. The results are sometimes amazing. And I want to illustrate that with these slides that I've shown to some people. So this is at the AACR meeting in New Orleans a couple of weeks ago, and this could be any poster session, could be anything at all: apoptosis, angiogenesis, autophagy, precision medicine, even genomics. People there, Then you go around the corner to an immune therapy, immune checkpoint, poster session, and it was like a mob. I mean, I thought there were fistfights going to break out because some people couldn't get to the poster of their choice. This is an example of a session that I went to on Sunday. It was an oral session on immune checkpoint therapy. I got there about 10 minutes before arriving, so I got a seat, managed to get a seat right at the very back. So the next day, I went 40 minutes before the session started, and I got a seat at the front, so I was able to shoot towards the back. A lot of these people over here, it's standing room only, and there were hundreds of people turned away. I mean, it's insane. It's crazy. The pendulum has gone from one ridiculous, side to the other, but that's the reality right now. And so Dan Duda and I and others have been discussing how we have to now reframe, our grant applications, bring in immunotherapy to some extent. And I think we have to do that with metronomic chemotherapy, so long as there's a scientific rational basis. And there is, as Francesco mentioned. And just to, end, one very interesting talk that I heard, at the presentation is what you want to do is to convert tumors from a non-inflamed phenotype where T cells are excluded or simply not present to an inflamed phenotype. And one way that you can do this is with, for example, traditional chemotherapy. And this raises the point that chemotherapy using MTD cytotoxic protocols could cause more cell killing, an increased inflamed environment, and also cause increased immunogenic cell death, increase maybe the mutational load. And if you follow that then with maintenance metronomic chemotherapy, for example using cyclophosphamide, this may be a very interesting way to now think about MTD followed by metronomic chemotherapy as having an effect through the immune system. That might explain some of the results of Cairo 3. It might explain some of the results of this study that was presented by Marco Corleone, where again, you have a maintenance chemotherapy regimen following induction. And it may be that what's happening here, induction followed by maintenance, is largely, or at least partially, an immunologic phenomenon. So let me end off with this. I think what we also have to ask is questions like, what is the impact of MTD, conventional versus metronomic chemotherapy, on expression of immune checkpoint mediators? What is their relative impact on infiltration and function of immune cells? Francesco went into this. What is the impact of other chemotherapy drugs beyond cyclophosphamide? And it was reassuring to hear from Francesco that vinorelbine might be very effective in this regard. It's not just cyclophosphamide. We have to look into this in more detail. And I think that I'll end with this, because David Waxman will talk more about this, because these different mechanisms, immunologic, anti-angiogenic, anti-vascular, they dose and the schedule of a metronomic chemotherapy regimen may have a huge impact on the predominant anti-tumor mechanism involved. So let me end with these acknowledgments. I've mentioned their names, most of them throughout the